and the slides are also visible.
Thank you. So thank you. It's a great pleasure being here. And I'm going to talk about precision monitoring and technology in diabetes care. Now, there are other speakers who are going to speak on this topic, but just to highlight and just to give an introduction to this topic, I thought, what better way than to discuss a few cases? So I will just discuss a few cases, and then we will listen to the other speakers who will take the topic forward. So on that note, let me start. So this is my agenda for today's meeting. I will look at precision monitoring during remote diabetes care. Second, I will look at continuous glucose monitoring for COVID care during the pandemic. And third part, we will look at post-COVID management of hyperglycemia. So let me go on to the first part, which is precision monitoring during remote diabetes care. So let me begin with my first case. A 33-year-old lady presented with hyperglycemia detected during pregnancy at 25 weeks of gestation. Now, this was her first successful gestation after undergoing 5 cycles of intrauterine insemination and 6 cycles of IVF. Her father had diabetes, and she has now been diagnosed with what was classical gestational diabetes at 25 weeks. You will also notice that her fasting is around 93 and the postprandial is 225. And because of the precious pregnancy and the high blood glucose levels, she was referred to us for further management. During the COVID lockdown, she was unable to commute to our hospital, and she approached us for a video consultation. So how to approach management in this case? So the advantage now is that earlier, people used to write their glucometer values in little logbooks, but today we have glucometers that sync to mobile phones and are data stored in the cloud. So she was checking her blood glucose levels every day, at least 6 times. You can see this is pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner. We published a series of cases of newly diagnosed gestational diabetes managed by telemedicine in the pandemic period. And these values that you see are actually the average glucose values. They aren't individual values, they are average. For example, in week 1, if the recording of the glucose started on Sunday, it will go on to Sunday, Monday, Tuesday, Wednesday, Thursday, Friday. So this is the average of that. So what we did is that we started on metformin 250 milligram twice a day. And then you can see that we continued that, and along with diet and exercise, we tried to bring the blood glucose levels to normal. You can see that with metformin, the mean pre-breakfast levels came down, post-breakfast levels came down, pre-lunch values came down, post-lunch values came down, and the glucose levels were controlled, and eventually she delivered a healthy baby. So this was the 3 cases these were the 3 cases of gestational diabetes that we managed, newly diagnosed gestational diabetes that we managed during the pandemic period. And you can see the average blood glucose levels. Not to say that these glucose levels are perfect. They're not perfect, but there is a reluctance to go very aggressive on telemedicine consultation. And what is important is that we get the best control possible and that the mother and baby remain healthy. So this is another case, and I just highlight this because we have sessions and time in range coming up. But I just want to highlight that sometimes glucometer itself can provide you with time in range reports. So this is a 32-year-old lady with twin pregnancy, currently at 32 weeks of gestation. She's here for gestational diabetes management and hypothyroidism. You can see that her values are pretty recent. These are the values in May and 2021. So last month, these are the values in April. The fasting is 80 to 90. And after breakfast, the value is 120. Before lunch, it's 80 to 90. After lunch, it's 130 to 138. Now, before dinner, it's in the 80s. But after dinner, the values are a little high. She's taking metformin at bedtime, and as you can see, the pre-diabetic, the HbA1c in November 2019, before pregnancy, showed pre-diabetes. What you will find is that her average glucose was between 28th of April to 11th of May, the average glucose was 112, and between 12th May to 25th May, it was 107. The standard deviation, which reflects variability, has also come down, 26 to 23. In the 15-day period, she has been doing blood glucose levels reasonably well, 27 and then 28. So reasonably well over 2 weeks. The average number of readings a day is at least 2. In India, 6-point glucose monitoring is not always possible, but I want you to look at this graph. This shows the various times of the day. And you'll see that it's after dinner and occasionally after lunch, there's a small red dot. Otherwise, glucose levels are pretty under good control. Just to tell you that it's not necessary to buy expensive continuous glucose monitoring devices, and self-monitoring of blood glucose levels can give you some valuable information. It's not only about the cost. Many doctors and many patients are worried about using technology for continuous glucose monitoring, and not everybody is going to be willing for such technology use. So for them, we can go back to the good old glucometer, and you can see that some of these glucometers, connected glucometers, can also give you time in range. You can see the time in range before a meal, the time in range after a meal, and the total time in range of 89%. We are told that in pregnancy, the time in range should be 80% or more. And here you have around 89%, and you can see there's no hypoglycemia. I'm not trying to say that these values are perfect and we've achieved perfect control, but I'm just trying to highlight the point that, glucometers can also provide very, very valuable measures of time in range. So coming back to this patient, doing very well with diet, exercise, and metformin, I think it is important to realize the power of the simple glucometer in detecting time in range, because these softwares are now available everywhere. So you can see the time in range, and you can see the other data, and you can see the little dots of hyperglycemia that have appeared. So I've come to the first 1/3 of my presentation. I talked about remote monitoring, precise monitoring during using technology for remote diabetes care during pandemics, where patients not able to come. Let me just look at continuous glucose monitoring for COVID care during a pandemic. Now, during this wave, in the Chalaram Diabetes Hospital, though we are a diabetes hospital, we did open a COVID section. And because of the surge in cases, and unfortunately, the cases have come down. Of course, this particular patient was admitted a long time back before the second wave in another hospital, but this patient was wearing a real-time, an intermittently scanned Libre device continuously. So even during the hospitalization, he was wearing that. So we could get some insights, and we could also remotely manage him in consultation with the doctor on site. Now, I just want to add that, so this is a 50-year-old gentleman. So before his getting COVID, he was on liraglutide, Lispro, and Degludec, and sugars were very well controlled, and he was using a freestyle Libre device. But once he got COVID, you can see on 19th March, this is just 3 months back, you can see he was given steroids. Incidentally, he had spikes of fever. His initial RT-PCR was negative, but we did the CT scan at our hospital, and we found that CT scan showed pneumonia. Subsequently, he was diagnosed with COVID, and he was given steroids, and he was, then you can see the steroids caused a spike in hyperglycemia on 19th and 20th. Of course, he was admitted in another hospital at that time, and you can see the blood glucose levels going up, but you can see he was wearing the CGM device. That's what I wanted to highlight. And then you can see that on 19th May, the steroids were started. 20th May, the sugars started going higher and higher. And by 21st May, the sugars had really gone high. So this patient obviously requires a basal bolus therapy. But if you look at the pattern, immediately if you look at the pattern, you'll see that it is a basal that requires more adjustment because the basal to prandial distance isn't much. So what you can see what happened to this gentleman, you can see he was on Lispro 886 and Degludec 35, and on 19th steroids were started. Till then, you can see he was doing very well. His averages sugars was 147, 146. The daily average was very good, and you can see the monitoring, the frequency of monitoring. On some days he was checking 30 times a day, some days he was checking 37. So good monitoring. But you can see that once steroids were started, the blood sugars rose up to 227, 288. So he was eventually shifted to the ICU. And in the ICU, of course, we had no control because it was in another hospital, depending on the bed situation. And he was managed by the intensivist, and the blood glucose levels remained high throughout. So what I want to highlight is that after he was shifted out of ICU, you can see the blood glucose levels coming back. So in addition to helping in preventing hypoglycemia, because these scan devices can even prevent hypoglycemia, you can see how his checking came down during his ICU stay. Because in ICU, of course, you depend on capillary glucose monitoring. You cannot use freestyle liberate devices in the ICU when sugars are continuously fluctuating unless you want to prevent hypoglycemia. And you can use that, but you still need to do capillary glucose, which is what we do in our ICU. Now, after that period, his blood glucose levels came down to 196. So showing you that, so what continuous glucose monitoring does, I shouldn't be saying this, but it really helps us to also understand glucose physiology during situations that eventually, when we gain that knowledge, we can intuitively learn things and manage the next patient better. Of course, in future, artificial intelligence will take over and help this management. So again, to give you a snapshot, he was given his first dose of steroids on 19th March. So 15th to 31st March, he had COVID. And you can see during that time, he was in another hospital. And you can see his A1C was 11%. The glucose monitoring indicator was 11%. His average glucose was 269. The time above target was pretty high. The median value was above again. But again, once his COVID got recovered, and this is in March, and in May, his COVID got recovered. He came and saw me last month. He was back to his old dose of Lispro, Degludec, liraglutide was restarted, metformin was restarted, and he was 6 weeks post-COVID. And you can see the glucose monitoring indicator is 6.5. His average glucose came down to 139. The time in target is a healthy 80%. So just to highlight that we can understand physiological processes like steroids, increasing blood glucose levels, or a viral infection increasing the blood glucose levels. And then you can see it coming down. And during this period, when steroids are weaned off and patient getting better, you can titrate the dose of insulin online with a diabetes educator to make sure that the values are normal. So I've looked at my second case. In my first case, I showed you simple glucometer used in a pandemic situation where pregnancy-related diabetes patients not able to visit hospital, worried about visiting the hospital because of the pandemic, worried about traveling huge distances to visit a hospital. And these patients can be managed with a glucometer that syncs to the cloud and can also be accessed by the diabetes care team. So I showed you that case. I also showed you that many glucometers connect to the cloud and you can get time in range. Is that time in range as good as a CGM or continuous glucose monitoring based time in range? I don't know. I don't think so. But in India, something is better than nothing, and not every patient will afford CGM or will want to go for it. And glucometer based time in range is an option. The second part I showed you is that how a patient's blood sugar levels rose and came down after steroid and then after viral infection, and how aggressive glucose control could have helped. Of course, just to say that understanding physiological processes can be very important. As you can see, this patient's glucose remained high in the ICU. Of course, as this was in another hospital, I was trying to connect with the doctor there. But of course, It's not easy to control glucose during the hyperinflammatory state with pneumonia and steroids, and they must have tried their best. But again, the good news is that after this patient got discharged from that hospital, came back to me, we were able to adjust doses, and on liraglutide and basal bolus therapy, he did well. Now I come to the third case. Now, before I go to the third case, I would like to add that these are only cases where we used our best clinical judgment in managing this case. In the discussion of cases, maybe you might have a better way of treating. I might not be completely correct. So we will discuss that in the panel discussion to come later on, or if there is time for discussion. But now let me go on to the third case, a very important problem. We know that mucormycosis is now very common in the post-COVID setting, and that the mean period, in several studies, the mean period for appearance of mucormycosis after COVID is about 22 days. We know that mucormycosis is because of several things. People have talked about steroids, sugar, the swab, the supplement, humidify, so many things. But the two things we know we can correct are steroids and sugar. Now, once the patient has COVID and gets discharged from the hospital, you can see that insulin is given, but sometimes, as the disease gets better, insulin can be rapidly tapered and stopped. That's very important, because otherwise patient will go into hypoglycemia. If you suddenly stop insulin, hyperglycemia can result, and that's not good given this mucormycosis situation. If you do not taper, then hypoglycemia can occur. So how to adjust, precisely titrate hyperglycemia in the post-COVID setting? So again, I'm showing a case here. This is a 62-year-old lady with type 2 diabetes on medication since 2014. Once she got COVID and she was admitted in the hospital, she was started on insulin. She was discharged on 16th April and came back to the OPD. And she was taking 3 injections of regular insulin, 10, 10, 10. And she was not taking a basal, of course, at that time. But then the RBS was 103. She had a history of ischemic heart disease, and she had a stent put in. And we could see that her at that time, this was the picture. So this is very, very common in certain situations, though this is a Diabetes India meeting and we are all diabetologists. Among doctors, many people who don't practice diabetes regularly, they like to give 3 injections of regular insulin without giving a bolus. That can cause a lot of hypoglycemia and fluctuation. So for this patient, on 7th May, we stopped the regular insulin. And instead of 10, 10, 10 of regular insulin, we put her on basal glargine, 16 units at bedtime once a day. I added glipizide and metformin, which was a kind of treatment she was on earlier, sulfonylurea metformin, added vildagliptin, and of course, statin and aspirin were all continued. Now, what happened is that this patient was worried about hypoglycemia, therefore we put her on CGM and advised her to come for regular follow-up. Just a moment, please. So just a moment here. So what we did is that once we started insulin glargine on 7th May, from 7th May to 15th May, we asked her to do a CGM testing. And along with the CGM, of course, if she had hypoglycemia, she would check. And of course, many of these CGMs can be connected to mobile phones now. So what happened is this 62-year-old lady with type 2 diabetes on medication started on insulin. And you can see that in this case, the time in range was kept between 70 to 154. We wanted a little bit more tighter control. And you can see the median was well in control, but there was some hyperglycemia and hypoglycemia. And eventually, the time in range was, because of the hypoglycemia, up to 23% on 15th May. At the end of this, we reduced glargine to 8 units. Now, this is the status from 15th May to 21st May. You can see that now the timing range is about 81%. The time below range is 18%. Daily average is 98. There's very minimal nocturnal hypoglycemias here, and the median values are normal. So you are reassured now. This is from 15 to 21st May. You are reassured that there is no hypoglycemia. Patient is only on 8 units of glargine, so you can easily stop. So time in range of about 81%, time below range of 18%. So we stopped the glargine insulin on 21st May, and she continued to do well. So friends, I've come to the end of my presentation, but I want to just summarize the 3 points I made on how precision monitoring and technology can impact diabetes care. First case, I talked about glucometer-based remote care of pregnant mothers with gestational diabetes who are worried about infection and coming to hospital during a COVID wave. In my second case, I showed you how real-time glucose may potentially help us understand the various glycemic fluctuations because of steroids, COVID, hospitalization, ICU, and how the post-COVID care can be titrated and patient can be put on the original treatment with good effect. In my third case, I discussed the post-COVID management of hyperglycemia because after COVID, the glucose shouldn't be high given the mucormycosis situation. And after COVID, the glucose shouldn't be low because patient will get hypoglycemia. So the insulin has to be rapidly tapered, titrated, and reduced. And continuous glucose monitoring is a fantastic way to decide whether insulin can be stopped and patient can go back to original oral drugs. So what I have done here, these are the telemedicine use in diabetes 2021 framework by the Government of India, just published recently. It is a document brought out by the Indian Council of Medical Research, and this is for cancer, diabetes, cardiovascular disease, and stroke. And I was honored to be part of the panel which wrote the framework for telemedicine use in diabetes. And this was led by, of course, the venerable Dr. Unnikrishnan, under whose guidance we made this telemedicine use in diabetes framework. I urge you to find this document, read it, because I think telemedicine is here to stay, but telemedicine is not for everybody. Telemedicine could serve as a triage system for sick patients to come. And also telemedicine may be a way for low-risk patients and chronic follow-up patients, but telemedicine cannot replace face-to-face care, and that is important. As we know, the wave receding and the COVID cases coming down, we are seeing an uptick in the number of people visiting for non-COVID problems. So friends, it has been a pleasure discussing this topic with you. And once again, good wishes, greetings, be well, and thank you all for listening to me.